Imagine a catastrophic neurological storm that just completely takes hold of a child's brain. But at the time of the very first seizure, doctors actually diagnose it correctly only like 0.6% of the time.
Yeah, 0.6%. It's incredibly rare to catch it right on day one.
Right.
Yeah.
It's wild. We are talking about Lennox-Gastaut Syndrome, or LGS, which is one of the most severe early onset developmental and epileptic encephalopathies. So our mission today for this deep dive is to cut through all the immense diagnostic confusion surrounding severe childhood epilepsies.
And there's a lot of confusion out there.
Oh, absolutely. So if you're listening and you want to understand how the brain's networks can just profoundly malfunction, we're pulling directly from the latest classification guidelines from the ILAE task force, and also some comprehensive data from the Continuum Neurology journal.
Which is, the gold standard for this stuff.
Exactly. We really want to unpack exactly what LGS is, why its electrical signature in the brain is kind of a moving target, and why pinning down this specific diagnosis is basically the ultimate gateway to getting targeted help for a child.
Yeah, and jumping back to that 0.6% statistic you mentioned.
It's just staggeringly low.
It really is. But it perfectly illustrates the overarching challenge here. Because LGS, it's not a static condition that just presents fully formed on the first day. It's an evolving network disorder.
Meaning it changes over time.
Right. We're dealing with a pathology that essentially hijacks the brain's developmental trajectory. So the clinical presentation and the electroencephalographic footprint, the EEG, they both morph significantly over months or even years.
Which brings up a pretty glaring systemic problem that the ILA paper highlights. There's this really pervasive tendency in the clinical community to misuse the Lennox-Gastaut Syndrome label as like a catch-all bucket.
Oh, definitely. A huge catch-all bucket.
Yeah. A clinician sees a child with early onset intractable seizures that lead to falls, drop attacks, and they just reflexively attach the LGS label.
Right. They see a drop attack and think, must be LGS.
Exactly. But treating every severe epilepsy with drop attacks as LGS, it's like calling every fast red car a Ferrari. It might look similar at a glance, but the mechanics under the hood are entirely different.
So let's unpack this. Why is using this label so loosely actually dangerous for patient care?
Well, this raises an important question, right? Because that diagnostic blurring has really severe prognostic and therapeutic consequences. When clinicians use LGS as just a generic descriptor for intractable early onset epilepsy, they completely fail to distinguish it from other distinct conditions.
Like what, for example?
Like myoclonic atonic epilepsy, or MAE. Now, MAE also presents with multiple seizure types and those explosive early onset drop attacks.
So they look super similar on the surface. Very similar. But its underlying network dynamics and its long-term prognostic map are markedly different. Basically, MAE generally carries a much better cognitive and seizure freedom outcome than LGS.
Oh, wow. So handing a family the wrong label.
You're preparing them for a completely different clinical journey. You're setting the wrong expectations.
And the sources are really emphatic that retaining the strict, precise LGS criteria is what physically opens doors for treatment, right? Like it's a regulatory gateway.
Yes, exactly. A gateway. The FDA and other global bodies, they've approved specific licensed anti-seizure medications exclusively for patients with the actual LGS diagnosis.
Exclusively. So if you don't have the exact label, you can't get the meds.
Right. If a patient is just grouped under a generic severe epilepsy umbrella, they are often entirely excluded from accessing the targeted therapies that are proven to modulate this specific network disorder.
Okay, here's where it gets really interesting, because that precision essentially forces the therapeutic pathway. So what are the strict rules for entry? The sources talk about a mandatory electroclinical triad.
Yeah, the mandatory triad. To access those treatments, a patient must meet these criteria. The first mandatory requirement is the presence of multiple drug-resistant seizure types starting before age 18.
And crucially, one of those types must be a tonic seizure.
It must be a tonic seizure. That's non-negotiable.
But the literature emphasizes just how stealthy these tonic seizures can be. Like, we're not always talking about an overt, sustained rigidity that throws a waking child to the ground. Paint a picture for us. What do these actually look like?
Yeah, so a tonic seizure is basically a sustained increase in axial and limb muscle contraction. It can last anywhere from 3 seconds to 2 minutes. But, like you said, they are stealthy. They preferentially hide in non-REM sleep.
In sleep, so a parent might not even see it happen.
Exactly. The visual signs might just be restricted to a slow upward rolling of the eyes, maybe a brief facial grimace, or even just a transient apnea like a pause in their breathing. But obviously, if they do happen while the child is standing awake, they can forcefully throw the patient off balance.
And that's the classic drop attack.
Right, the drop attack.
Okay.
But the sleep state dependence is a really defining feature of the underlying pathophysiology here. During non-REM sleep, your brain naturally engages in synchronized slow wave activity.
Okay, so that's normal for everyone.
Normal, yes. But in the LGS brain, these normal bilaterally distributed networks are highly susceptible to becoming pathologically hypersynchronized.
So the sleep state kind of acts like an accelerant.
Precisely. It acts as an accelerant for these abnormal thalamocortical loops, which is what triggers the sustained muscle contraction that defines the tonic seizure.
You know, I found a fascinating and honestly totally counterintuitive detail in the Continuum article regarding the sleep dependency.
The benzodiazepine paradox.
Yes, the acute administration of high-dose benzodiazepines. We traditionally use these as rescue medications to halt prolonged seizures, right? But the text says they can actually exacerbate these tonic episodes in LGS patients.
It is a striking pharmacological paradox.
Yeah.
So benzodiazepines enhance GABAergic inhibition, which, generally suppresses neuronal excitability. It calms the brain down.
Which sounds like what you'd want during a seizure.
Right. However, they also alter sleep architecture. Specifically, they increase prominent fast activity in the brain.
Ah, okay.
And in the specific network wiring of an LGS brain, inducing that fast activity and pushing the patient into a modified sleep state can inadvertently trigger the exact hypersynchronous bursts that cause the tonic stiffening.
That is wild. So you're trying to stop the seizure, but pharmacologically, you're shifting the brain into the exact state that favors an LGS seizure.
Exactly. You're inadvertently feeding the storm.
Which really reinforces why an empirical trial and error approach to medication is just so dangerous here. You really have to know the specific network wiring you're treating.
You do. Which brings us to the second and third pillars of that mandatory triad. We have the cognitive and behavioral impairments, and then we have the highly specific EEG fingerprint.
Right, the EEG. And reading that is tricky. The interictal EEG meaning between seizures has to show a generalized slow spike wave of less than 2.5 hertz, and also something called GPFA during sleep.
Yes, generalized paroxysmal fast activity, or GPFA. This is the true electrographic hallmark of the LGS network. Yeah. What's fascinating here is what we're actually looking for.
What does it look like on the screen?
We are looking for bursts of fast electrical activity, typically 10 hertz or higher, that just abruptly and synchronously light up across bilateral brain networks. It's the electrophysiological correlate of those sleep-bound tonic seizures, even when no visible muscle contraction occurs.
Even if the patient isn't moving at all.
Right. The brain is having the seizure electrically, even if the body doesn't show it.
But how do doctors know it's LGS and not, say, MAE or infantile spasms?
Well, the frequencies and the patient's state of arousal are the key differentiators. So in MAE, those generalized spike waves are significantly faster, typically between 3 to 6 hertz. They completely lack that sluggish under 2.5 hertz rhythm of LGS.
Okay, so MAE is faster. What about infantile spasms?
With infantile spasm syndrome, the spasms occur predominantly upon waking up, not falling asleep. And they typically last less than 3 seconds. LGS tonic seizures last longer than 3 seconds. And like we said, they dominate during deep sleep.
So it's pattern recognition built on exact timing and physiological state.
Exactly.
Okay, so that rigidity of the electroclinical criteria, that loops us perfectly back to our opening statistic. The reason only 0.6% of cases are diagnosed at the first seizure is because this whole highly specific footprint, the slow spike wave, the GPFA, the sleep seizures, it simply hasn't formed yet, right?
Right. It hasn't formed. The LGS network is actively constructing itself during a critical window of neurodevelopment.
The data shows a peak onset between 3 and 5 years of age. And I read that 19% of children with infancy onset seizures eventually evolved into LGS.
Yeah, it's a significant chunk.
And about 20% of LGS cases evolved directly from a preceding infantile spasm syndrome diagnosis. So the electrical storm literally morphs as the brain matures. Like the fast chaos of an infant's brain coalesces into the slow spike wave of a 4-year-old's brain.
Yes, and if we connect this to the bigger picture, we are witnessing the mechanics of an epileptic encephalopathy in real time.
Break that term down for us. What does that actually mean?
In an epileptic encephalopathy, the continuous abnormal electrical firing is not just a symptom of a damaged brain. It is an active agent of destruction.
The electricity itself is causing the damage.
Exactly. The sheer volume of interictal epileptiform discharges,
Yeah.
the constant slow spike waves and GPFA bursts, it actively disrupts normal physiological rhythm.
Right, because if the brain relies on specific slow wave sleep rhythms for like memory consolidation and synaptic pruning, flooding those exact same networks with 10 hertz fast activity would essentially just jam the developmental signal.
Jamming the signal is a great way to put it. It creates a state of aberrant neuroplasticity. This high-frequency synchronized activity is basically outcompeting normal neural signaling.
And this is happening right during the period when the child is supposed to be rapidly acquiring language and motor skills and social skills.
Exactly. And that constant barrage is why we see a plateauing and frequently a devastating regression of developmental milestones.
So they actually lose skills they already had.
Yes. The electrical activity itself drives the moderate to severe intellectual disability that we see in over 90% of LGS patients, along with severe behavioral comorbidities like autism spectrum traits and aggression.
So what does this all mean for treatment? Because if the electrical signature is actively degrading the developing network, identifying the epicenter of that storm becomes a literal race against time.
A total race against time.
The ILAE guidelines strongly emphasize securing a high-resolution brain MRI at the very onset of suspected LGS, like checking the hardware before you blame the software.
Right, because structural causes are the most common root etiology. The imaging is searching for things like focal cortical malformations, or the tubers you see in tuberous sclerosis complex, or regions of acquired hypoxic damage.
Like from a lack of oxygen at birth.
Yeah, exactly.
Yeah.
But the clinical utility of the MRI in LGS cannot be overstated, particularly when it comes to reinvestigation.
Reinvestigation, you mean scanning them again years later?
Yes. The Continuum data highlights that re-imaging older LGS patients using modern, powerful 3 Tesla or 7 Tesla MRI protocols frequently reveals structural etiologies that were entirely invisible on the weaker 1.5 Tesla scans taken, say, a decade ago.
Oh, wow. So the tech just wasn't good enough back then to see the tiny flaws.
Right. We are now routinely finding subtle focal cortical dysplasias, these microscopic areas where neuronal migration went awry during gestation.
But wait, if you find a highly localized focal dysplasia that's driving a generalized bilateral network disorder, that completely flips the therapeutic paradigm, doesn't it?
It absolutely flips it. It opens up the possibility of resective epilepsy surgery.
Which means actually removing that tiny piece of brain.
Yes. Removing or surgically disconnecting that single structural epicenter can sometimes dismantle the entire downstream LGS network.
That is incredible. The ultimate precision intervention. But what happens when the high-resolution MRI shows totally normal cortical architecture? Where do doctors look then?
Then the diagnostic hunt immediately shifts to genetics. And the standard of care has aggressively evolved here. The Continuum article points out that exome sequencing is now the recommended first-line genetic test for unexplained DEEs.
Exome sequencing, which is a profound leap beyond those old single gene panels they used to do.
Yeah, completely.
Because by sequencing the entirety of the protein coding region of the genome, which is what, the 1 to 2% of our DNA that actually builds the cellular machinery,
Yeah.
we've discovered that there isn't just one single LGS gene, right?
Right, there's no single LGS gene. Instead, pathogenic variants across hundreds of entirely different genes can disrupt synaptic proteins or ion channels, and they ultimately converge on the exact same LGS network failure.
That convergence is fascinating. So you can have a mutation affecting a sodium channel, and someone else has a completely different mutation affecting GABA receptor signaling. Yet both of their brains ultimately wire themselves into the exact same slow spike wave and GPFA patterns.
Exactly. The brain's response to the genetic flaw is stereotyped. Furthermore, identifying these pathogenic variants usually reveals them to be de novo mutations.
And we should clarify that for you listening because it's a common misunderstanding. Just because a condition is genetic does not necessarily mean it's inherited.
Crucial distinction, yes.
These de novo mutations are completely new, spontaneous errors occurring during early embryonic cell division in the child. They are not passed down from the parents.
And that carries massive weight for clinical counseling. Identifying a de novo mutation radically shifts the conversation with the parent.
Right.
It entirely removes the phantom of inheritance.
Which must be a huge relief for parents worried about having more kids.
Huge relief. And it halts the diagnostic odyssey of endless lumbar punctures and metabolic screens. It provides a clear molecular mechanism.
And knowing the exact molecular mechanism allows doctors to anticipate specific comorbidities associated with that specific gene.
Yes, and more importantly, as precision medicine expands, we are beginning to trial targeted therapies that address the specific molecular defect, rather than just broadly attempting to suppress the downstream electrical seizures.
Moving from treating the symptom to repairing the underlying network flaw.
Exactly. The rigor of classification here dictates the trajectory of a patient's life. Rigorous classification ensures we are not just managing chaos, but systematically dismantling a specific pathological network.
Well said. So, to quickly synthesize the journey we've been on today, LGS is not just a lazy shorthand for severe childhood epilepsy with drop attacks. It is a highly specific, evolving developmental and epileptic encephalopathy.
With strict mandatory rules.
Right. The diagnosis demands strict adherence to the electroclinical triad. Multiple seizure types, including those stealthy sleep-bound tonic seizures, cognitive impairment, and a distinct EEG fingerprint of generalized slow spike wave and paroxysmal fast activity.
And pinning down that exact diagnosis, whether structural or genetic, is what unlocks the targeted therapies.
Exactly. But before we wrap up, there is a final, deeply compelling neurological mystery directly from the sources that we want to leave you with regarding the long-term trajectory of LGS.
Yes, this is the part that really makes you think.
Right. The text mentions that after the age of 16, the majority of LGS patients no longer exhibit that hallmark slow spike wave on their EEG. The defining electrical fingerprint literally vanishes from the tracing.
It just burns out.
But the clinical seizures and the severe cognitive impairments, they persist into adulthood.
So we want you to consider the implications of that vanishing fingerprint. If the hypersynchronous electrical storm that defines the syndrome eventually morphs or disappears as we age, what does that indicate about the permanent physical wiring of the brain?
Right. The network is capable of profound adaptation. Exactly. If the adult brain no longer requires that specific abnormal electricity to maintain its dysfunction, understanding exactly how and why that signature disappears provide a roadmap for reversing the ingrained cognitive damage later in life. Untangling that late stage neuroplasticity is going to be the next great frontier. Thank you for joining us on this deep dive.